Welcome and thank you for joining today's webinar on jail reentry for people with substance use disorders, Part 1, Meeting Immediate Needs with the National Association of Counties and the Institute of Intergovernmental Research, funded by the Bureau of Justice Assistance, BJA. This webinar is part of a three-part series that will be offered during the month of March. Part 2 will be offered on March 16th at 2 p.m. Click the link in the chat box to register. My name is Elin Lee, and I'm the Program Manager for Justice at the National Association of Counties. Before we get started, just a reminder that this session is being recorded and will be available on the NACo website after the event. Please feel free to use the chat box to pose any questions you may have throughout the webinar, and we can address them during the Q&A portion of this session. During today's webinar, you will hear from experts and leaders highlighting strategies counties can use to partner with government agencies and service providers to share information and develop jail reentry strategies that encompass training and workforce development, housing attainment, and connections to behavioral health treatment. First, before we get started, I'd like to pass it over to Kathy Rowans from IIR to introduce herself and for opening remarks. Kathy?
Thanks, Elin. Hi, everybody. My name is Kathy Rowans. I am a Senior Research Associate at the Institute for Intergovernmental Research, and we provide training and technical assistance to sites across the country under the Bureau of Justice Assistance's, BJA's, Comprehensive Opioid Stimulant and Substance Abuse Program, or COSAP. And so we just wanted to provide a quick overview of COSAP since you'll be hearing from sites who are funded under this grant program. So COSAP provides financial and technical assistance to states, localities, and tribal governments to help them plan, develop, and implement comprehensive efforts to support those who are impacted by substance use disorder. So since 2017, the Bureau of Justice Assistance through COSAP has supported innovative work that aims to reduce overdose deaths, to promote public safety, and to support access to treatment and recovery services in the criminal justice system in over 500 site-based projects and demonstration projects across the country. And today you'll be hearing from sites that are participating in 2 of those demonstration projects. First is our Rural Responses to the Opioid Epidemic Initiative, which supports 21 rural sites across the country as they worked to identify gaps in prevention, in treatment, and in recovery services for individuals who have substance use disorder and encounter the criminal justice system in their communities. And then the sites are now implementing or enhancing activities to close those gaps and really just to strengthen efforts to address the substance use crisis in their communities. And then the second demonstration project is the Building Bridges Between Jails and Community-Based Treatment Initiative. And that is supporting 14 sites across the country as they are working to implement medication-assisted treatment in their jails and also to enhance collaboration between jails and community-based treatment providers. So that's it for me. I know that was super quick, but we don't have a lot of time. So just wanted to give an overview of these projects before you hear all the good nitty-gritty from the folks that are actually doing the work. You can learn more about these projects and COSAP as a whole by visiting cosapresources.org. I can drop that into the chat box, and then I will certainly stay on and happy to answer any questions at the end. But so that's it for me. Thank you so much. I'll turn it back over to you, Elin.
Thank you, Kathy. I would now like to introduce you to our panelists today. First, I will pass it over to Glenn Sayes, who's the Director of Substance Abuse Solutions from the Upper Cumberland Human Resources Agency in Tennessee. Director Sayes, would you like to introduce yourself?
Yes, I would. Thank you very much. Glenn Sayes from the Upper Cumberland region, which is middle rural Tennessee, 14 county region there. And I am the director and creator of a department within the Human Resources Agency, the Substance Abuse Solutions Department.
Thank you so much, Director Sayes. I'll now pass it over to Ms. Olson. Would you like to introduce yourself, Ms. Olson?
Absolutely. Thank you, Elin. My name is Jocelyn Olson. I am over here in Lewis and Clark County, which is in Helena, Montana, the capital of Montana. I am our Detention Center Education and Reentry Coordinator. been with the Department of Criminal Justice Services for just about 4 years now, and in this current role for a little over a year. So excited to be here and to share what we're doing.
Thank you so much, Ms. Olson. Next, we have Robert Dean from Arkansas Rural Health Partnership.
Thank you. I'm Robert Dean. I'm from NACo County. It's the farthest southeast corner in Arkansas. I'm project director over the BJA and ARCORP projects grants with the Arkansas Rural Health Partnership. Thanks.
Thank you all. Next, we'll jump into our presentations. First, we'll start off with Director Sayes to share some of his efforts in Upper Cumberland County.
Great, thank you very much. Pleasure being here with you today and presenting a little bit of what we're doing. Very limited on time. The last time I did this presentation, I had 3.5 hours, so try to see how much we can get through. Go ahead, next slide. I think you will understand a lot about what we are doing if you understand me. I am a lifelong entrepreneur professionally. I have a 21-year background in high technology, especially dealing with manufacturing systems and the best practices of putting manufacturing companies together to work efficiently. Next slide. There's no better illustration of manufacturing process than Toyota. If you can follow the little diagram here, the blue square over here, the dealership, person goes into a dealership and they order a Toyota van. The production company makes a production order, production plan, and then it goes into the sequential plan of pulling parts and going into the manufacturing process of putting parts together, assembling it, and coming out with a final product that goes back to the customer. So this is the world that I lived in for about 12 years, manufacturing companies and putting together best practices and ways of getting good finished products out of the end of the line. Next slide. What I am going to encourage us with today is taking that professional passion that I had for doing things correctly and in order, and then combining it with my personal part of the passion. Let me introduce you to my son, Nathan. Next slide. I have 2 sons. The little boy on the right, on the left is now a retired major from the U.S. Army. The little blondie is Nathan. He was my son that was a professional snowboarder. Next slide. I'm from Seattle originally, and we had real mountains in Seattle, and snowboarding is an actual profession in Seattle. There's a picture of Nathan doing one of his stunts on the cover of one of the magazines during that time period. Nathan was involved in a major accident on the hill. A 9-inch titanium rod was embedded in his arm with a plate and 6 screws in his shoulder. And they took him to the hospital and gave him his first 90-day prescription of opioids, then his second 90-day prescription of opioids. This is my son from about 5 years ago when he was deep into his heroin habit. And so his mother and I went through many months, years actually, of the stress of wanting to help our son. How do we move him from where he is when he would come to us and say, I need out of this? And we would try to get him out, and there would be holes in the system. We could not get him through an entire process. And I became determined that there was a way of taking a person who is coming to you begging for help and putting them through a complete process of recovery. We all talk about continuum of care, but it is rarely exercised. Next slide. So I went back to this was really the night that I got most motivated. This was the local county jail where I was picking Nathan up one night between 1 o'clock and 2 o'clock in the morning. And as he came out, I said, boy, I'm really impressed with how many other parents and friends are here to pick up people that are being released in the middle of the night. He said, Dad, those mostly are the drug dealers here to pick up people and get their customers back. That really hit me hard, that we were not taking, especially with people being released from jail, and putting them into a continuum of care. So let's go back over to my little illustration here of the manufacturing company and how a manufacturing company has a plan and they put the automobile through their plan. Next slide. But instead of an order coming from the dealership, they walk into one of our facilities, one of our offices, and they say, I need help getting out of this addiction, or the court sends us, or community corrections sends us that person just being released from jail. We need to do an intake, a client pathway, and then put them into a pathway that we have pre-configured. Next step, or next slide. Instead of a car, we have an individual that comes to us. Maybe they have detoxed in jail and are ready for treatment, or maybe we have to convince them that they should be ready for treatment. Sometimes that is, as probation is, the threat of going back to jail. Whatever it takes, though, use the carrot and the stick, get them agreeable to a treatment program so that you're giving them clarity of mind with the treatment program, and then putting them into the whole continuum of service that they need. The housing, the job, the transportation. Go ahead and give me the next slide. The two things, if you only remember two things from my presentation today, these are the original quotes from the manufacturing system from Toyota. The order information is quickly incorporated. Do not wait a week, 2 weeks, 6 weeks before you start dealing with that person that's coming out of jail. They are the most ready they will ever be when they're coming out of jail. Get them quick, don't delay, get them into a program, get them into a treatment program if needed the same day that they come out of jail. Don't let them have 2 weeks to get their legs back or whatever they want to call it. You will lose them during that time. So getting the process started quickly. And then the number two thing, timely production. Listen to what this says about a manufacturing: efficiently producing vehicles with different specifications one at a time in a timely manner while ensuring high quality. The only word that you need to change there is our client that is coming to us, efficiently taking that client and putting that has different specifications. Each person is different. They need to be handled one at a time in an efficient, timely manner where we are checking the quality every step of the way. And that gives us the finished product of a person. Now, let me show you how we do it real quickly. Next slide. We are operating what I call a modified hub and spoke. Hub and spoke was started in Vermont back about 17 years ago, with the hub being a treatment center. Person would come to the treatment center would treat them for their substance use, but then they would send them out for employment, training, legal assistance, dental, medical, re-socialization. We do all those things, but we do not do any of the services. We are an independent hub that only serves as the traffic director. We direct the person to the next step of their recovery process. It's kind of like a manufacturing process. We turn them into a number and put them through the process. The difference is, as soon as they come to us, that big blue RC that is in the chart there, that is for the recovery coordinator. They come to us, we assign a recovery coordinator. That recovery coordinator will get them into the appropriate treatment program. There's no wrong door for treatment program. We get them into the first best treatment program. We average less than 48 hours from the time that we receive a person and do an intake till the time that we have them in a treatment program, and we will hand deliver them to the treatment program. You can't just depend on one treatment program. We have placed people over the last year and a half in a total of 43 different programs. We're looking for the best fit where we can get them in immediately. When they're ready to come out, the same recovery coordinator is there to greet them when they come out of the treatment program, to take them to the next steps: the employment, training, housing, transportation, legal issues, et cetera, et cetera, et cetera. We stay with our clients for a 2-year period. 2 years. We don't know of anybody else that's doing that. We will stay with that client for a 2-year time period through lapse and relapse a lot of times, but we will not give up on them. We stay with them and work with them for that complete continuum of care. Next slide. The purpose that we have within our department is clarity of mind. This is the treatment. You've got it when we take a person, whether they're coming to it, no, don't go away. When they come to us, whether it is off the street or out of the prison system or parole, they are coming to us, and I would say 70% of them need to go into a treatment program. Sometimes it's an IOP, sometimes medicated assistance, sometimes residential. We will go to all 3 of those types of programs, but we've got to get clarity of mind. The brain has got to start healing so that we can begin working with them on a long-term basis. Once we get a little bit of the clarity of mind, we can start offering the stability of the environment, a decent place to live, a good job, transportation between the two, a new set of friends and support. That gives them the ability to discover their purpose in life, and that is our objective. Lots of good stories out there that I could tell you about successes that we have, but the main success that we have, and I don't think I included the picture. When my wife and I moved from Seattle, Washington 3.5 years ago down to Middle Tennessee, the hardest thing that we ever did is we left our son in Seattle. He was there in Seattle, living homelessly as an injecting heroin addict on the streets of Seattle. Just about 2 years ago, he joined us down here in Tennessee. And that is quite a story of a miracle that happened with that. Call me and I'll tell you what that is. But he came down here. He is now has been living clean and sober, paying the rent in a house every month for the last 18 months, full-time job with the same employer for 18 months, and is firmly in his recovery. And it's proof that you don't give up on a person, you stay with them. And that's after 14 years of living through his addiction. So if anyone would like to know more about the ifs, ands, and how we do this and how we're set up, I would love to spend time with you, but my time is up. How about that, Kathy? I actually did a pretty good time on there. Here are some of the, oh, I forgot about this. I did put numbers back here. In the last 1.5 years or last 19 months, we've done intake on over 1,000 people. We have placed into treatment 184 individuals, over 100 people into permanent housing, and you can see some of the other statistics there. We'd love to share more with you. If you're interested, please get in touch with me. Our information is at the end of the slideshow. Thank you.
Thank you so much, Director Sayes. Next up, we have Ms. Olson from Lewis and Clark County. I will go to the next slide.
All righty. So again, my name is Jocelyn Olson. I am the Detention Center Education and Reentry Coordinator here in Lewis and Clark County in Montana. So we can go on to the next slide here. So briefly, what we're going to touch on today is the MAP Bridges program that we've implemented here in Lewis and Clark County Detention. We're going to focus on the reentry piece of that and some of the obstacles that we've experienced along the way. On to the next one, please. So first of all, what is MAT? So MAT is medication-assisted treatment. So working with folks who struggle with opioid use disorder, helping them to get on a medication to help with that, and then provide the wraparound services that are necessary for sustaining recovery. Next slide. Okay, so here in Lewis and Clark County, in 2019, our county sheriff came to us and said, we need to do this MAP program. How do we get this going? And so we created a planning initiative that was a 9-month-long project, and we had all of the main folks come together to figure out how we're going to make this happen. How are we going to bring MAT into Lewis and Clark County? So then in 2020, we received 2 grants, one from IIR that we call our peer support grant, and that allows us to work with peer support specialists from our federally qualified health centers here in Helena. And then we also had our COSEP grant, which allowed us to do all of the other stuff that's involved with the MAP program, allowed us to really implement the program and get things going. Go ahead to the next slide, please. So one of the big things that we always talk about is partnership. It is important having all of those stakeholders come together, work together to make this happen. So you can see we had the Sheriff's Office, the Department of Criminal Justice Services, which is the department that I work for, and then our 2 federally qualified health centers, Helena Indian Alliance, Leopoldtia Clinic, and the Peerview Health Center. Next slide, please. So when we came together, we had to identify our goals, right? And overall, our biggest goal is to help folks struggling with an opioid use disorder, help them to get into treatment, to use the medications appropriately so that they can stay away from, whatever opiate they chose to use, and to really create connections between the community and the correction system. All in the name of, reducing recidivism, increasing public safety, and helping our community. So again, we focus on our team. Who does it take to make all of this happen? And so on this slide, you'll see folks all the way from our county commissioners, detention captain, many other folks from the sheriff's office, folks from the federally qualified health center, providers there, as well as many folks in the criminal justice services department. Next slide, please. So kind of reflecting on what Glenn said earlier, it is so important that as soon as somebody comes to the detention center, that you start working with them right away. You have a limited time frame. And so what we like to say is that really reentry begins at booking. Go ahead to the next slide. So when someone's booked into the detention center, we like to ensure that if somebody is on a MAP program in the community, that we are continuing that care while they are in our facility. So go ahead to the next slide. So we have our first alert. So when somebody comes into the detention center, they go through many booking questions with the officer. And as you can see here, we have some questions that are very pointed toward substance use disorder. And so these questions allow us to decipher whether we have individuals who are struggling with opioid use disorder and individuals who are on a MAP program. So we identify folks who are on the MAP program, and that allows us to continue that medication. It also helps us to find those individuals that are coming into our facility who are struggling with opioid use but haven't quite made the step yet to gain treatment. Next slide, please. Okay, so after the booking questions and that very initial screening, we then have the medical team come in and do their screening. So they look at folks, they determine if someone is detoxing from an opioid, and then we also have checks, medical checks. So if we miss somebody for whatever reason during that initial booking screening, then the medical team can come in and find them when they do their checks with everybody. So we're not missing anyone. Go ahead to the next slide. So as soon as the medical team deems somebody eligible for the MAP Bridges program, our behavioral health case manager then steps in and tries to navigate the entire map of the criminal justice system. Namely, where is this individual going once they leave our facility? That factors in significantly. So next slide, please. So Here I am. So we have folks who are leaving our detention center and they are going back to the community, right? But there are also folks who are leaving our detention center and they're going to prison, or they're going to a Department of Corrections program, or they're going to a sober living facility or a treatment facility. Wherever they're going, it's important for us to identify that. For folks who are going into the community, we have our federally qualified health centers whom we can connect them with. Please to the next slide. So that's where I really show up and really start moving things around. So at this time, we figure out which federally qualified health center an individual would like to work with, whether it's Helena Indian Alliance or Pureview Health Center. Once we have that decided, I then reach out to the certified behavioral health peer support specialist from that organization. And I schedule a time for them to come in and meet with the individual who is going to either start on the MAT program or who has been on the MAT program to ensure that continuity of care. Next slide, please. So once we have a time set for the peer support specialist to come into the detention center, they establish rapport with that individual. They then do some case management, ensure that they have all of the initial paperwork set up with the federally qualified health center, ensure that the individual has a place to live once they're being released, and look at any other social indicators of health. So what do we need to do to ensure that this individual is successful providing those wraparound services? And I saw somebody throw that in the chat box earlier. So go ahead to the next slide, please. So like I said, this is going back to the point at which an individual is booked into the detention center. So we have everything established, and right away, if we know that somebody's going to be on the MAT Bridges program, I created this little checklist, and we have two versions of this checklist that you see, and we put this in the individual's folder so that officers know no matter when this individual is released, they need to be connected to somebody in the community. So one version of this release checklist is for individuals who are taking the MAT medication here in our facility, and we use Suboxone here in our facility. The other version of this checklist is for individuals who are not taking the medication in our facility, but will be taking the medication once they are released. Either way, we want to ensure that the individual who is leaving our detention center is leaving with connections. Go ahead and go to the next slide there. So that is what leads us to our hot handoff, what we call our hot handoff. So on that release checklist, if you noticed, it had our two peer support specialists from each of the FQHCs and their contact information. So as soon as an officer sees that checklist in somebody's folder and they're releasing that individual, they know, I need to call this peer support, let them know that so-and-so is being released. As soon as that phone call is made, the peer support specialist then comes to the detention center and is here as soon as the person walks out of the release door. That way, the individual, the peer support specialist, is able to help the individual get wherever they need to go, and main part, get connected to the clinic so that they can continue their treatment. Next slide, please. So some of the roadblocks that we've experienced, it has been a journey. So we realized when we first started bringing this program in, there were a lot of folks coming into the detention center who were unfortunately medication seeking, who really wanted that Suboxone, but maybe didn't qualify for the MAT program. So those are folks who, who maybe struggled with meth or other substances. And so one of the things that we've looked at implementing is drug testing. So as soon as someone comes into the facility and we have concerns that they're struggling with opioid use disorder, doing a drug test to see whether they have some sort of medication in their system or if they have an opioid in their system. And that'll really tell us what's going on. Some other things that we've experienced, we've had major issues with diversion. So individuals trying to save some of the Suboxone, some of that medication, either in their cheeks or in their teeth, so that they can then pull it out and sell it to somebody else who is in the facility. So we've had to come up with a way to disperse the medication while trying to avoid that. So we started crushing the medication, we place it under the individual's tongue, and do mouth checks and ensure that that individual is actually receiving the medication they need and not diverting it to someone else. Placement, I touched on that briefly with our behavioral health care case manager. Placement is a huge thing because there are many facilities that don't accept MAT medications, particularly Department of Corrections facilities. They won't accept anybody who's on a MAT medication, so we'll have to wean them off of the medication. There are some sober living facilities in the community who won't accept MAT medications. We're working on that. But really navigating that, figuring out where somebody is going, it is very difficult. And to go along with that, it's difficult to know when someone's going to be released from the detention center. So, you know, folks could go to court and all of a sudden the judge says, okay, we can release you out to the community, and we have an hour to make sure that they are connected and they have the supports that they need prior to and once they leave this facility. Go ahead to the next slide. So along with that, there have been times where we've missed that. We've missed the time of release. An individual they're on the MAT Bridges program, and they were released before we were able to get a hot handoff set up or anything else. And so we've tried to set some fail safes in there, if that's a term. So one of the things that we've done is partnered with Walmart, and they have a gift card from us, from our department. So if somebody is leaving the detention center and they need to continue taking their MAT medication, but won't be able to connect with one of the federally qualified health centers in time, then they can go to Walmart and get a very short time frame supply of their medication so that they aren't experiencing any withdrawals or any adverse effects once they leave the facility. That also gives us a little bit more time to ensure that individual connects with one of the FQHCs and everything gets rolling from there. Next slide, please. So something that I just wanted to throw in there that's really important to think about, especially when you're starting a MAT program, are policies and procedures. Policies and procedures are very important in corrections facilities, but they're also important when it comes to starting something as diverse as this program and as complicated as this program can be. So ensuring that all of the expectations are outlined clearly ahead of time and that everybody knows what's happening at any given point in time, so that we can limit at least some surprises and ensure that things move slowly. So the other thing too that I wanted to throw out there is whenever somebody is released who is on our MAT program, so whether or not they are taking Suboxone, they are released to the community with Narcan, or naloxone is what some folks call it. And so that is to try and help alleviate overdoses in the community. So ensuring that we're training folks on how to use that and getting that out there as soon as possible. Go ahead to the next slide, please. Thank you. That's all I have.
Thank you so much, Ms. Olson. Lastly, but certainly not least, I would like to pass it over to Director Dean from Arkansas to share some of his efforts. Director Dean.
How's it going? Good evening, everybody. My name is Robert Dean. I'm project director over the BJA grant, and this grant allowed us to have this next step recovery housing in El Dorado. I'll just kind of give a little background. In 2020, in our consortium meeting, we did a gap analysis and needs assessment for our service area. And so that includes, I believe it was 9 or 10 counties in our area. And after we did the needs assessment, the consortium realized there was no recovery homes for women in the service area. And so when we were in our implementation stage of the BGA grant, we were working with different people to try and find a women's recovery housing. We contracted with Chelsea McGill, and Chelsea is on the call with us now to do a women's recovery housing. A doctor was so generous to donate this house, and so other people in the community came together to help this with getting this off the ground. You can go to the next slide, please. In 2021, we contracted with Chelsea McGill, who I stated a while ago, to set up the women's recovery housing in El Dorado. I have a timeline on there. Chelsea, can you kind of give us an update on the timeline, if you have that with you now, from 2016 from present with the Next Step Women's Recovery Housing?
Yes, absolutely. Hi, I'm Chelsea McGill. I'm the program director of Next Step Recovery Housing. We were first Next Step Women, then we had Next Step Men, and now we are Next Step Recovery Housing. So I had a little setup, but in 2016, I was actually working for someone else that was kicking people out for not having rent. And, you know, our residents do have to, was like really quickly happening. Like they were coming in and it was like, you got to get a job in 2 weeks and you immediately need to be paying. And if you're not, you're gone. And so that's what led me to start our housing program. And so in 2018, we opened Next Step Women, and it was a really large house, or a lot of people in it, a lot of women. And then we went to, we moved that to Sherwood, Arkansas. And that was still 10 women. And then when COVID happened, we took on a men's home. And then we ended up finding Robert and opening up our El Dorado home, which has been such a blessing to the women in that area. And it's going really well. It's, you know, we opened during the pandemic and we have been thriving ever since. Thanks, Robert.
Yes, thank you. Just some requirements for the residents in the house that have a negative urine analysis through drug tests. All the medication has to be approved. They have to be cleared of physical and mental health diagnosis so that the next step can meet the needs of all the residents who want to be in the house without drugs and alcohol. All of the residents in the house are required to go to meetings, to get a sponsor, and to work in the community. And if they cannot work due to certain conditions in the residence, volunteer. You can go to the next slide, please. So I've got some data since the house has been opened. They started working on the house, I believe, in January of 20. That's when implementation of the VGA grant started. It opened in April of 21. Is that right, Chelsea?
Yeah, right in the beginning of April, into March.
Okay. And so since then, we've had around 13 women who currently reside. It's a 5-bed program. 2 women currently reside there. Since it started, 11 have been discharged. 6 of the 11 were discharged with compliance. 67 drug tests have been provided since July 1 of 2021. And of the 67, only 6 have been positive. So it's pretty good results. And Also with the women's housing, I know this is on Next Step Women's Recovery Housing, but also in the men's housing, which is in Clarksville. Got some data for there too. Just 20 men have lived there since July of 2021. 8 currently reside there, and then 12 have been discharged and 7 have graduated. And so right now, currently in the women's housing, we currently have 2, and Chelsea, I believe the beds, 3 more are waiting for other residents to come join. Okay. That's about all I have on that. We are thankful that we found Chelsea, and we're so grateful that we have a doctor that donated the house. If it wasn't for community members, we just don't know if we could get this project off the ground. And so we're just grateful for the doctor, community members, Chelsea and all her hard work, and everybody's support.
Well, thank you all so much, and thank you, Director Dean and Director McGill, for your presentation. I apologize, Dr. McGill, I didn't see you until the last minute. I apologize, but thank you so much for joining in on us and sharing your efforts in Arkansas. First, I would like to thank all of you all. We have now entered into our Q&A portion of today's webinar. I'd like to open the floor for any questions and comments. Again, feel free to use the chat box feature to pose any questions or comments you may have. I see we have a couple of comments in the chat. I see there's one question where it says, how do you deal with relapse?
I feel like were they, I didn't know if what Sal is asking me.
Yes.
Okay. Well, that's what, depending on the situation, it depends on if the person wants to get help, the situation of whether or not the person has drank or used, whether or not they have come to us, whether or not they even return back to the house after a relapse. So if they want to get to treatment, we will help them with that. And if they don't, they go on their way. Unfortunately, we have sent them with some naloxone kits. We have, I like what the other person said, stayed with them for as long as we could. I've actually taken people back again, and that doesn't always end up great, but we will try to work with them as long as we can. I'm a person in recovery as well, so I do a lot of that.
And this is Glenn. One of the things that we do with our program is we make a distinction between a lapse and a relapse. We distinguish a lapse is a use of a drug or alcohol. A relapse is when they've gone back into the old lifestyle. They've decided they're going to go back where they were. There's not a whole lot you can do about a total relapse. You can say, we love you and we'll be here when you're ready to change again. But for a lapse, a temporary use of a drug, we do not kick them out. We do not disqualify them. Now, sometimes if they have a lapse, a negative UA, their probation will be violated and they will go back to jail because of that. But we generally have a pretty good relationship with our officers, so that if it's a minor lapse that we are sure we can keep working with them, sometimes that will be overlooked. But there's a lot of articles that have been written on the distinction between a lapse and a relapse. I encourage you to look those up.
Ms. Olson, I think there was a question directed for you. What sort of housing options do you have for homeless clients reaching out to both of these programs? For the MAP program, is there an exit plan for completion of the medication? I think there's 2 questions there for you.
Right. So can you all hear me? Yeah. Okay. So I tried my best to answer that in the chat as well, but one of the main housing options that we really look for is a sober living facility. So we have a couple of them available for men and a couple available for women. If we could get somebody into a structured environment like a sober living facility, that's probably our #1 option. Although we do have folks who, sometimes that isn't an option. And so looking for other healthy relationships that the individual may have, other healthy environments where they can go to be supported in their recovery. So that's somewhat the first one. There, I could go on, but then the other question about completing the medication. So we don't look at that on this side of the process. We're really just trying to ensure that the individual is leaving our detention center with the connections to treatment. And so at that point, hoping we're successful in that, the individual will continue to work with their provider and eventually create a plan for completion of the medication if they want to wean off of it, or whatever it is that is best for that individual. So we really just want to make sure that that continuum of care that Glenn referenced is followed through.
Thank you. Also, I think this may be a question from Eric. Did any of the programs encounter issues with the community or stigma while developing these programs, and how did you resolve these issues? I think that's a question for all of you.
I'll go first. I mean, nobody, I don't think anybody really solves the stigma. Everybody fights with the stigma every single day. We've talked about setting up recovery facilities at like our local hospital, and then somebody will drive by like, oh, I saw Billy Bob at the recovery center. And so the stigma is always there. Every day we just try to talk about stigma and what we can do. And I think having awareness of stigma is the best, is just all we can do.
I've been doing this now for about 15 years, and stigma was huge back 15 years ago. Oh, it doesn't happen in my family. It's not any of my friends. But I think that's all changed in the last 5 or 6 years. Almost every single person. I was in a group meeting this morning. I said, how many of you have a personal friend or relative that is involved with addiction? And 90% of the people in the room raised their hands. And so I think stigma is still there. It's people still don't want that kind in their backyard for housing, but it's a whole lot. It is getting better as people realize this is the disease that needs to be treated, and people need to be treated with compassion, and compassion with treatment works.
So, and I'd like to speak to stigma as well. Working in the corrections field and trying to get a program such as Matt Bridges up and running, there is quite a bit of stigma. Officers not understanding or fully comprehending what it is that we're trying to do. A lot of folks believing that with MAP medications, all we're doing is replacing one drug with another drug. And so really what we've been trying to do to battle against that is educate. The more education we can provide to folks, the better understanding and the less stigma we have.
Thank you. Question from Shelby. What barriers did you face when starting your recovery housing in regards to zoning, billing, Medicaid, or insurance, if any?
That for me? For me specifically in Arkansas, so there's not any type of zoning specifically. There is like, how many ever people are in the house, like certain things have like bathrooms and stuff like that. But as far as like not allowing it in the community, that is not allowed in Arkansas. But now we did have to have just the same thing with businesses. They come in and the fire departments come in and check all the utilities and made sure we had fire extinguishers. And, but that's a lot of the first people's first question. Well, what about the zoning? And we have not had any difficulties with that here in our area. Now, however, we had thought about another area, a house that was thrown out there to possibly make a men's house. The neighbors did come together and ended up really, fighting to not have that in their area. And so, it happens.
All right, and then we have one more question from Philip. I think this is directed to you, Jocelyn. How did you set your partnership up with Walmart to provide MAT prescriptions for a week? So that's amazing.
Yeah, it was pretty challenging actually. So we had to figure out a way for our provider to send the prescription over to Walmart so that the individual could then go and pick it up. However, our provider isn't available 24/7. So we had to, it was all electronic. So the provider was able to set something up, kind of like an outline, or I'm forgetting the word right now, but a script, I guess. I'm forgetting the word, but something that the nurses could then send over to Walmart so that the prescription could be filled at the location. And then our department then had to take a preloaded gift card and give that to Walmart so that anytime we did need to use that service and somebody came in to get their MAT medications, they weren't paying for it. Walmart was just scanning our gift card so that it could come out of our grant funds. So I hope that makes sense, but it was a whole lot of communication among our department, sheriff's office, medical providers, the pharmacists over at Walmart, figuring out all of the pieces.
Wonderful. Let me see if there are any more questions in the chat box. We'll give it a few more minutes. We have possibly like 2 to 3 more minutes, maybe 1 or 2 more questions. If anyone has any questions, we'll give it a minute.
Looks like there's a question for me on training and education provided to the correction staff. So this is something that we've really been trying to figure out. So to kind of throw a curveball into all of this, our detention center was actually just recently renovated as well. So we have had many different policies and procedures put in place. We're still trying to figure all that out. And so we had our peer support specialist from Helena Indian Alliance come in and provide the MAT training to all of our sergeants. And basically what that was is what that training is about is talking about what MAT bridges is, what is MAT medication, how does it work, and what is our goal, who are we working with, so on and so forth. So we provided that to all of the sergeants with the hopes that it would trickle down from there. We also have posted it to, there's a website that all of our officers have access to where they have to go in and do certain training. So officers can access that information at any time, but they do have to go in, complete that training. And we we are onboarding many new officers, so trying to get that education to them as quickly as possible. And in terms of, long term, if it's going to be annual training, again, both the officers can go back to that specific training in the website that they use. However, we're constantly educating. I hope that makes sense there.
Thank you. Any more questions coming through in the chat? Give it a few more minutes. All right. Well, since there are no more questions, I would like to thank our speakers again for being here with us today and sharing their efforts within their own communities. I will also like to give a special thank you to IIR and to BJA for funding this webinar series. Again, as I mentioned earlier, this is a webinar series. It's a 3-part series, and we encourage you all to attend part 2 and 3 of this webinar. Part 2 will take place on March 16th, 2 weeks from today, and part 3 will be offered on March 30th at 2 p.m. You can use the link in the chat box to register for these 2 webinars. Again, special thank you, and hope everyone has a wonderful week. Take care and see you for part 2.
Thank you. Bye.
Thank you.